So hi everyone, I am Dr. Himadri. So let's talk about jaundice in newborn. We actually call it NNJ, that is neonatal jaundice, or NNH, that is neonatal hyperbilirubinemia. So what you actually understand about jaundice? Jaundice is the yellowish discoloration of the skin, sclera, conjunctiva, or the mucosa due to hyperbilirubinemia. So this hyperbilirubinemia is very important. Only yellowish discoloration is not called as jaundice. If this yellowish discoloration is due to hyperbilirubinemia, we call it jaundice. Okay. So this hyperbilirubinemia means increased amount of bilirubin in the blood. So this bilirubin value is different. In case of adult, if the total serum bilirubin is more than 2 mg per dl, then we can appreciate the jaundice. In case of newborn, this value is little higher, that is more than 5 to 7 mg per dl. Then only there will be a visible jaundice. Okay. So this NNJ, that is neonatal jaundice, could be of two types, that is it could be physiological jaundice or it could be pathological jaundice. Physiological means it is common and also seen in around 80 to 90% of the newborn. Okay, in case of term newborn we see in 60% of term newborn, but in case of preterm newborn around 80% preterm can have this jaundice, but the pathological jaundice is seen only in 10 to 20% of this newborn. Okay. So this physiological jaundice actually happens due to physiological immaturity of the newborn to handle increased amount of bilirubin which is produced in the body. So let's understand from where the bilirubin is actually coming. So this is the blood vessel. Here the newborn has actually the blood, and this blood is entering into the spleen, eventually getting degraded. You know that in the newborn the RBC half life is less than that of the adult, therefore more amount of bilirubin is produced, there is increased degradation of the RBC. And also in the liver there is one enzyme which is called as UDP-GT, that is UDP glucuronidal transferase, and which is responsible for converting the unconjugated bilirubin into conjugated bilirubin. Due to immaturity of this enzyme, so unconjugated bilirubin is increased. And also in GIT, what happens? From the bile, this conjugated bilirubin comes, and this is your naughty bacteria which converts the conjugated into unconjugated bilirubin. And this unconjugated bilirubin once again via enterohepatic circulation enter more into the liver as well as in the blood. So there is increased destruction. Number 2, physiological immaturity of this UDP-GT, and number 3, increased amount of enterohepatic circulation. All these three phenomena actually contributes to this physiological jaundice. Now let's talk about the pathological jaundice. Few causes about the pathological jaundice we will discuss in detail. So this is your beautiful spleen, rather baby spleen, and also look here, this is the blood vessel. The blood is entering into the spleen. So some causes you can think like what are those causes where there could be increased amount of RBC destruction, like RH incompatibility, ABO incompatibility. It could be G6PD deficiency or hereditary spherocytosis, and AIH, that is autoimmune hemolytic anemia. All these causes, that is hemolytic causes, there is increased amount of destruction of the RBC, and from the RBC bilirubin is produced. Don't worry, we have another video where we have discussed about the bilirubin metabolism, how it is coming from your RBC. So another cause, that is polycythemia. Look, there is increased amount of the RBC which is present in the blood as a circulating form. They eventually gets destructed and eventually your hyperbilirubinemia. And this naughty bacteria, that means sepsis. Sepsis is very common in newborn. Sepsis eventually leads to destruction of the RBC. So all these causes, there is increased amount of bilirubin production. And also, in the birth trauma, the baby is naughty, or rather not naughty, angry rather. So there is cephal hematoma, and also your subgaleal hemorrhage. In cephal hematoma, subgaleal hemorrhage, these are produced due to birth trauma. Okay, And we have another video you can watch, the how the cephal hematoma and subgaleal hemorrhage these are produced. And ultimately there is increased amount of bilirubin production. And in liver, we have this another friend, that is UDP glucuronide transferase, UDP-GT enzyme, and whose main action is to convert your unconjugated bilirubin into conjugated bilirubin. So some conditions where the enzyme is not working properly, automatically unconjugated bilirubin will be high, like in Crigler-Najjar syndrome. That is in type 1, totally absent UDP-GT. In type 2, there is reduced activity of this UDP-GT. Okay, and also in Gilbert syndrome, and also in IDM, that is infant of a diabetic mother, the same issue, and also in congenital hypothyroidism. So remember, we have thyroid hormone T3 T4, and this T3 T4 is responsible for the proper maturity of this UDP glucuronide transferase. If the T3 T4 is absent, automatically that is reduced. And also in galactosemia we actually have cholestasis. Okay, so on one hand we have increased bilirubin production, and in another hand we have a reduced bilirubin clearance. Both of these things is basically contributing towards hyperbilirubinemia. So another issue, look, this is the baby's beautiful GIT, and in GI tract what is happening, let's say the baby is getting reduced amount of breast milk, which we call as breastfeeding jaundice, or maybe in breast milk jaundice. Don't worry, we will be discussing in the second part of this video about both of these entities. And also in meconium ileus, and also in intestinal atresia. In case of intestinal atresia, the stool is not being passed. So what will happen? Whatever conjugated bilirubin is coming, that will be converted into unconjugated bilirubin and eventually increased EHC, enterohepatic circulation. In Hirschsprung disease also the same thing. Okay, there is obstruction, physiological, basically there is obstruction in case of Hirschsprung disease. And what is happening? The conjugated bilirubin is basically converted into unconjugated bilirubin by the action of some bacteria, and this unconjugated bilirubin once again via enterohepatic circulation entering into your liver and also in the blood, automatically high amount of bilirubin. And another conditions, let's talk about this thing as well, that is which predisposes the neurological dysfunction or the neurological injury that occurs due to this. So we have unconjugated bilirubin. Unconjugated bilirubin is not soluble in the water. Okay, that's why in the blood, that is in the water medium, this is being transported via albumin molecule. But in this is the blood-brain barrier. If the blood-brain barrier is damaged, or in case of preterm or in case of birth asphyxia, more unconjugated bilirubin. And if the albumin is less, automatically unconjugated bilirubin will be high, albumin less than 3. And some drugs which dissociates bilirubin from the albumin, that is ceftriaxone, and some there is neurological dysfunction which is in. So there are 4 headings under which you have to discuss about this pathological jaundice. Some few concepts about the physiological jaundice versus pathological jaundice. This is important. So what is physiological and what is pathological? So we discussed the few causes. Now understand what is physiological versus what is pathological. Please draw with me this diagram, this chart, which is basically describing all this. In physiological jaundice, the jaundice will appear after 24 hours of birth, that is after 24 hours of age. And also it will be less than 5 in day 1, in day 2 less than 10, and in day 3 it will be less than 15. In day 3 it could be like 12 to 15 mg per dl in case of term, but in case of preterm the value could be little higher. And also in day 3 it may be more than 15 mg per dl in case of preterm. But remember, in term baby the jaundice should come down by day 3 of age. By day 3 of age. But in case of preterm, the jaundice must come down by day 3 to day 7 of life to fulfill the criteria of physiological jaundice. Now let's talk about the pathological jaundice. Okay, pathological jaundice means the jaundice which will appear within 24 hours of life, and also this is more than 5 mg per dl on day 1. So please write clinical jaundice which is appreciable within 24 hours of age is always called as pathological jaundice, number 1. Number 2, the TSB value on day 1 more than 5, on day 2 more than 10, on day 3 more than 15. That is per day more than 5 it is increasing. So this is pathological. Okay. And another thing, please remember, if there is yellowish discoloration of the palm and sole at any time, we call it pathological jaundice. This is very important. If there is yellowish discoloration of palm and sole at any time. Okay. Now let's see, if the jaundice persists more than 2 weeks or more than 3 weeks, that is in term baby, if it is more than 2 weeks, in preterm it is more than 3 weeks, we call it pathological jaundice, one form of pathological jaundice, that is called as prolonged jaundice. This is what is prolonged jaundice, more than 2 weeks or more than 3 weeks. Okay. And another thing, suppose you have done the TSB, that is total serum bilirubin, this is more than 95th percentile. And also if the child is having clinical features of BIND, bind, that is bilirubin induced neurological dysfunction, or this persisting jaundice. These are 6 clinical markers or the clinical pointers that will tell that this is pathological jaundice. Okay, now discuss about the few causes like in ABO incompatibility, how this is causing your pathological jaundice. Okay, so this is the mom's side and this is your baby's side, and in between we have placenta. Okay, so for ABO incompatibility to happen, mother should have O blood group and baby should have either A or either B blood group. Okay, in case of O blood group in the mother, look here, this is the RBC having only H antigen, no A antigen, no B antigen, only H antigen. As don't have any A or B antigen, automatically anti-A or anti-B antibodies are produced in case of mother. But in case of baby, let's see if the baby is having A blood group. So what is A? A means the RBC has this H antigen. On the top of this H antigen, is having A antigen. The H framework is same, but in top of this H there is A antigen, and also there is anti-B antibody. Okay. Oh, for the simplicity we made one mistake here, that is, please change the color coding. So the blue color is anti-B antibody and the red color antibody is anti-A antibody. Okay, so anti-B and antibody both are present in mom, but in case of baby only anti-B antibody is present. Now this anti-B or anti-A antibody are mainly of IgM category. You know, IgM molecule is a very big molecule, but IgG molecule are very small, and IgG can pass, but IgM it is very big, it cannot pass via placenta. But predominantly IgM is produced because these antigens are of sugar, that is of carbohydrate in nature, and also this IgG whatever had passed, especially anti-A antibody, it will bind with the site of this A antigen. Automatically there will be hemolysis in case of baby. So this is a very sad thing. There is hemolysis in the baby, and we will having this pathological jaundice. So what is the treatment for ABO incompatibility? You know this, double volume exchange transfusion, DVET. Okay, and this DVET we will be doing with PRBC as well as FFP. Just wait, just write for this time, for this sake, and we can discuss in detail later in the part 2 of this video. We need O blood group, and the RH will be RH as baby. Okay, so baby will be given with the O blood group PRBC and FFP of AB, and also the RH same as baby. If positive, give positive. If the baby is having negative, give negative. So O means there is no antigen. Okay, only H antigen, no A or no B antigen. And this AB means there is no antibody, no anti-A, no anti-B. Automatically you can understand if there is also hemolysis, it will be treated like this. Okay, now let's discuss about the RH incompatibility. So once again, draw what is the issue in the mother as well as in the baby. In mother there is RH negative and the baby is having RH positive, then only there will be RH incompatibility. Okay, and in RH negative mother there is no anti-RH or anti-D antibodies. In the first pregnancy, remember, no issue, but from the second pregnancy and onwards the issue will start to come. Okay, so during first pregnancy, If there is any feto-maternal hemorrhage, some amount of baby's blood will enter into the mother's circulation. And this baby's blood, as it is Rh positive, coated with these D antigens. So these black dots are representing your Rh positive PRBC. So in the mother, the immune headquarter will recognize this as a foreign material and eventually keep on producing the antibodies against this domain. And that is from second pregnancy and onwards, these IgG antibodies, because this Rh antigen is basically of protein in nature. Therefore, the antibody directed against it produced are IgG. This IgG, as it is small inside, it can easily cross the placenta and coming into the baby's circulation. Now this is disaster. Baby is having Rh antigen and this antibody came and eventually there is hemolysis. Treatment is double volume exchange transfusion. Okay. And PRBC will be using mainly of O or the baby's blood group and also the negative and AB negative. So few words about the clinical approach to a case of neonatal jaundice or neonatal hyperbilirubinemia. You must know it because this is important and very common case. And all the neonates should be visually inspected for the presence or absence of jaundice twice daily for the first 3 to 5 days of life. Okay, so all the neonates, irrespective of gestational age or anything, should be visually inspected for the first 3 to 5 days. Okay, or by a TCB, that is transcutaneous bilirubinometry. And what we will use, that is Kramer's rule for physical examination. Please remember, some high risk neonates should be noted here because these are very, very important. They will be having pathological jaundice earlier, like gestational age less than 40 weeks and presence of hemolytic disease like ABO incompatibility, RH incompatibility, or maybe G6PD. Okay. And if you can see, there is scalp hematoma, like cephal hematoma, maybe subgaleal hemorrhage, which you can easily see. And in case of a Down's phenotype child, and also IDM, that is infant of a diabetic mother, these are high risk neonate to have pathological jaundice. Therefore, in rounds, when you are looking for the baby, you must keep these points in your mind. Okay. After that, suppose the baby has serious jaundice. So you need to know what is actually called as serious jaundice. Serious jaundice means the forms of pathological jaundice actually. So the jaundice which is appearing within 24 hours of age, or yellow palm and sole at any time, or clinical features of acute bilirubin encephalopathy like high-pitched cry, lethargic, or maybe the hypertonia in the baby in the form of opisthotonos, that is like this, the baby is bending, or maybe the convulsion. Okay, and also the transcutaneous bilirubinometry at any time more than 15 mg per dl. So the baby is having serious jaundice, you know what we call as serious jaundice. And suppose the baby is having serious jaundice, then the first step is don't wait. Start phototherapy immediately or DVT, double volume exchange transfusion, as per the requirement. Please don't worry, we will be discussing about this in little later. And also you have to send the blood for measurement of TSB, that is total serum bilirubin. And the second step of this management is, of course, is to identify the cause. You will not be treating only this patient. You need to identify the actual cause of it, and also providing the supportive care and follow up to these babies. Okay. So, how will you identify the cause? It can come from history. Okay. So, what are the things is that will ask in the history in this patient? So here family history is very, very important. Remember, because in family history you can get the history of hemolytic anemias, or maybe the sibling having features of jaundice, that is sibling had jaundice, or you can easily get from the antenatal history some issues like the torch infection, maybe like a fever with a lymphadenopathy. All these things will suggest torch infection maybe, and also in the gestational diabetes in the mother, or maybe some drugs which can precipitate the hemolysis in G6PD. Okay. And also the another history from the birth history. This is also very, very important. if the birth asphyxia is present or not, and also the birth trauma, which can eventually lead to your cephal hematoma or like that. And also breastfeeding, that is history of breastfeeding. If there is reduced feeding, there is BFJ, that is breastfeeding jaundice. So these are common things is you'll ask in history. In the examination, look for any signs of dehydration present or not, or if the child is not gaining appropriate weight, reduced amount of calorie, blood is concentrated, more amount of bilirubin, that is hyperbilirubinemia. And also look for the hemorrhages, that is pallor or petagy, or look for the hepatosplenomegaly. Why? Because in hepatosplenomegaly you can get this thing in the congenital infections. Okay. And the third thing is your laboratory investigations, which is needed for diagnosis. First, your ABO incompatibility, which is very common, like mother's blood group, BBG means baby's blood group, and DCT, direct comb test, and CBC and peripheral blood smear, very important for diagnosis of ABO incompatibility or RH incompatibility. And also second thing, G6PD quantitative assay, very important. And of course, the TSB, direct bilirubin, and unconjugated bilirubin you have to send. And another thing, sepsis screening is very, very important. Blood culture is important after sepsis screening. Metabolic workup is very, very important here. So please don't forget TSA is very, very important. Okay. So as we were talking about the examination of this baby with jaundice, we have to use the Kramer's zones. Okay. So the few points about examination, you have to examine the child in the bright natural light. And number 2 is that don't use any yellow or off-white background, because in off-white or yellow background, child may falsely look yellowish rather. And also examine the blanched skin, and we have to use the Kramer's zone. Okay, the Kramer's zone is from head to this neckline. This is zone 1, and if the jaundice is visible only in this area, we have to consider the jaundice approximately 5 to 7 mg per dl. And also in the zone 2, in the chest and the upper abdomen, chest and upper abdominal region, this region, that is 7 to 9. And for zone 3, the lower abdomen and also the thigh, this area. Okay, 9 to 11 mg per dl. And also if this is 4 means legs and arms. Look, this portion of the leg and also arm, that is 4, and it corresponds to 11 to 13 mg per dl. And also 13 to 15 mg per dl is your palm and sole. Look, this palm and the palm as well as the sole, this becomes around approximately 13 to 15 mg per dl. Okay, so that's and also as we have already discussed, the jaundice present in palm and sole, that is 15 mg per dl or more than that, which is always pathological. Okay, so if you are still watching me, you could have enjoyed this content. So please consider giving likes if you really like it, and also subscribing to my channel for more such videos in the future.